Great. I appreciate being here. I always look forward to these meetings and appreciate the EHE Foundation. I am a pediatric oncologist who became interested in the world of vascular anomalies that includes tumors and also malformations about 20 years ago. So today we're going to talk about Sirolimus 101 and the importance of education in rare disease, because it's really important, as all of the speakers have talked about having families and patients really understand the treatments that they're getting. I have a lot of things that, for some reason, my slides aren't advancing. Whoops, sorry about that. I do have some disclosures. I am on the advisory board of Novartis and also am a consultant for Novartis. And some of these slides actually are very repetitive because others who have spoken have brought them up. But EHE is a rare disease in adults, but it's even rarer in children. We obviously know that the course is hard to predict. Clinical presentation is varied. We don't really have a true risk stratification, and this is so untrue compared to other oncologic diagnoses that we have even in kids. We talked about the gene fusions. We talked about there being no molecular targets, but amazing to hear the research that has happened and is going on right now. And so rare tumors in general have many questions, and I love this snowflake analogy. And I can tell you that in vascular anomalies, everything really is a snowflake. So we talked a bit about treatment, so observation, surgery, interventional procedures, chemotherapy, biological agents that are there, the more chemotherapeutic agents, but no real clear directed targets. And I'm going to talk, so most of this talk is really going to be on rapamycin and sirolimus and really the history of it and how we came to use sirolimus or other mTORs like everolimus for the treatment of patients that have vascular issues, whether they be tumors or whether they be malformations. And so I'm not sure everyone knows this story. It's sort of a serendipitous story about rapamycin and how it was discovered, but it was truly found in the soil on Easter Island, so the island Rapa Nui, in 1972, and it was found by an amazing scientist, Dr. Suren Segal, who basically was looking, there are many ways that we find drugs in general, and they were looking for other means of drugs. And so they found this drug, which was isolated from streptomyces, and found that it had many properties. And some of the properties included an antibacterial, because that's where it was found from a bacterial organism. It had some antifungal properties. It was an immunosuppressant. So initially it was used as an antifungal medicine. And because it had some toxicity and because of the immunosuppression nature of it, it then started to be used in renal transplant patients. And so the first FDA approval for it, and the only FDA approval for it as of now, is in renal transplant patients for rejection. Back in 1972, there was a program at the NIH where they actually were screening different drugs and things that were found in biological agents to see how they did with cancer. And they screened rapamycin and found that it had anti-tumor effects, that it decreased or inhibited the proliferation of many different tumors. And so when this was being done in the 1970s, all of those agents that were screened, only 2% of them made it to the next step to go into practice or to even go into more discovery. And rapamycin was one of those drugs that made it. And so I know this is a horrible picture, but this is another rare vascular tumor called Kaposiform hemangioendothelioma. And it is a tumor. It's an intermediate tumor in the WHO classification. And it occurs mostly in the pediatric population, the majority in infants, but it can occur in the toddler period, but it also can occur in adults. And this was a story of a patient that really made a difference to all of us, because if it weren't for what this patient went through, we would probably not, or maybe we would, but we wouldn't as quickly be thinking about the use of mTORs for vascular problems in general. But this was a patient that came to see me when I was in Cincinnati, in our group in Cincinnati, when the baby was 2 months old, and had immunizations given. And in 24 to 48 hours after the immunizations were given, the leg looked like the top picture. In retrospect, this infant had a tiny bruise in that area, but no one thought much of it. It was a little spot. And then this patient was sent to a local hospital in a small area of West Virginia, but a hemonc doctor there recognized this and was questioning whether this was caposiform hemangioendothelioma, because this infant had a platelet count that was less than 3. So a normal platelet count is above 150,000. And also a fibrinogen that was undetectable, and a normal fibrinogen is greater than 200. So also had some signs of bleeding. We treated this patient with our standard of therapy, and that is with chemotherapy agents like vincristine and steroids, and then with Cytoxan. And then we actually sat at tumor boards and we added other anti-angiogenic agents that didn't work. So in the meantime, we had been working with some basic scientists on this pathway, which you see on the right, and this is something called the PIK3CA pathway. And we had a hypothesis that this could potentially be involved in vascular anomalies because there was a tumor suppressor gene, so a germline problem, that 20% of patients with PTEN had vascular anomalies. And then there were other germline changes. So germline means a gene that you get from your mother or your father that also led to vascular anomalies, but the majority of them were not germline. And so we proposed that maybe this tumor and others were secondary to something called a somatic mutation. So changes that happen when the body genes are getting together to move and make us, our germline genes make us look different, but our somatic genes actually make us look like human beings. So we need our somatic genes and genetic processes to get to grow. And this whole process here is involved in growth. It's involved in a cell being a muscle cell, and a cell being a fat cell, and a cell being a blood vessel. And so we decided, since this infant who was now 8 months old was basically not doing well and was going to need to go to palliative care, then the parents really wanted to move to something else, that we would try sirolimus because it was being used in other studies for neurofibromatosis, and it's an oral agent. And we so decided to try it on this patient, and this is what happened. So not only did her tumor over time decrease, it didn't completely go away, so it didn't eradicate this completely, but her platelet count normalized and her fibrinogen normalized. And from this, we, looking at this pathway, this PIK3CA pathway, have been able in the vascular anomaly world with some tumors and also some malformations to identify the phenotypes of what the diagnosis is and link them to what the somatic genetic problem is. So KHE has been, and that was the rare tumor that you saw, has been linked to GNA14, but this has not panned out to be a causative somatic mutation. So all of these other things have causative somatic mutations, but KHE is very much like EHE because we truly have not found a cause for it. We don't have things like CAMTA. We're still looking to see sort of why this tumor has had such a wonderful response to mTOR. But this still broadened and opened vascular diseases in general up to being treated with mTOR. And so we know that sirolimus has been reported in EHE. There is the paper that another physician was referring to about new molecular insights. There have been some retrospective reviews using sirolimus not only in adult patients, but also in pediatric patients. And our findings have been that there has been some response to mTOR inhibition, but also, most importantly, disease stabilization. So how do we think it works? And there are some animal models looking at not only the tumor caposiform hemangioendothelioma, but also other vascular tumors and other malformations. And we've noted in some animal models that it does increase apoptosis of cells, cell death. It inhibits tumor growth, but it more so, as we were talking in our previous talk, stabilizes the tumor. So in KHE, there are spindle cells that some of them die, but in general, some of those spindle cells change to a more mature vascular phenotype. It also can interfere, though, with basic metabolic processes, and that is what a cell needs to survive. So this is another way that we have found that it probably helps. So we talked about when we should use and consider medical management, particularly sirolimus, and I list things here. I know that a great talk was given about this, and I agree with it. The only caveat that I'll say is that I am a pediatric oncologist, and we have really found, and I'm not sure that pediatric presentation of EHE is the same as the adult presentation. And I think it's going to be really, really important for us to have this registry so that we can figure these things out. Because if I think about my patients that I have had, and it may be that they're being referred to me and maybe they're not diagnosed right away, but with their symptoms and their presentation, it's hard for me to follow, to just watch and follow. So think of an EHE patient that has multiple areas of disease and is already complaining of pain and GI upset, who's a 5-year-old versus someone who's a 40-year-old. That patient has to live with their cancer for a lot longer. So I think we really have to think about the difference in pediatrics and also in adults. So just going back to sirolimus, there is a typical dosing that we use. The dosing is very different for a pediatric patient versus an adult patient. So pediatric patients, really from PK analysis that we did with that first study almost 20 years ago, need BID dosing. And if someone is being treated to treat the tumor to really have that tumor stop progressing, or to get as much apoptosis as possible, the initial levels that we use. And so we're able to follow drug levels, which means that we can see if that drug is being metabolized in individuals, and we have kind of a treatment dose that we know we want to get to, and we can go for that treatment dose. People are different as far as how they metabolize the medicine. And so it's been so amazing to have drug levels and to also have the ability to follow them and know what your target levels need to be. So usually when we're treating someone initially, it's a target level of 8 to 10. And then when patients stabilize and we sort of are in this maintenance period where we keep them on sirolimus, we decrease that dose level to 6 to 8. We also know that this can interfere, and I'm going to talk about side effects in a little bit, but we need to get labs to look at the metabolic, to look at the liver, to look at the kidneys, to look at other things, the CBC, about every 1 to 3 months. Adults are treated a little differently. So adults usually have a daily dosing. The levels are gotten at 12 and 24 hours. And typically an average, and this is in the vascular anomaly world, a maximum dose for an adult is 2 milligrams a day. We do go over that if we're trying to get to a higher trough level, but it's really important to know what your goals are for your trough level, how you're going to get to those goals, and to see how someone is tolerating that dose, because sometimes we'll change an adult to 2 times a day as well. So side effects, again, children tolerate, kids are not little adults, and kids tolerate this medicine a bit better than adults do. But mouth sores are common. Sometimes in the older age group, headaches are common. You can get irregular menses, ovarian cysts, fatigue, GI upset such as nausea, diarrhea, constipation, anemia. And that's secondary to how the iron is metabolized. You can have an increase in your lipids, You can have lymphedema. So when this is used to treat transplant patients, you can have lymphedema. I have not seen it in any of my EHE patients. And rarely in the transplant world, there is thrombosis, capillary leak, pneumonitis, and the question of a male infertility. It is an immunosuppressive agent. So when we're giving it to younger patients, we actually think about what the target dose is that we're giving to them. And we do prophylactically treat them with for pneumocystis prophylaxis. Long-term, we think about skin cancer. We have used this in over 400 patients with over a 20-year experience, and we have not seen any long-term effects in children. So this is typical of what everyone has been saying. So when we start a medicine, and when it's even sirolimus, we really discuss the patients in an interdisciplinary approach. And I call it interdisciplinary because our team is usually there together in meetings and conferences. We talk about, what is the diagnosis? Is the diagnosis appropriate? What is it about the diagnosis that makes us want to treat? What are our goals for treatment? How will the response be measured? What is the trough level that will be used and why? What is the follow-up? How often the patient should be seen in our interdisciplinary clinic for reevaluation? We also talk about special circumstances such as the age of the patient, any other medications they're on, or any other medical issues. We talk about supportive care. I don't necessarily use supportive care as much in adults as I do in children, depending on what their past medical history is, that might change things. And then we give our patients, we had our study initially, but now we have a standard of practice that we use, and this standard of practice is given to our patients. Length of treatment is very, we are using this to really, this doesn't cause and get rid of and cure EHE. So we're using it as a way to suppress this tumor from growing. And so we have to really figure out a way that we're going to assess for symptoms, assess for scans. We talked about an initiation period and a maintenance period, and then we actually wean patients off of the drug. If they're doing really great, we do want to give them a trial where they're off of the drug, and we usually do a weaning for that. So in summary, rare diseases are challenging. Every patient is different. I loved that snowflake analogy. This requires all hands on deck, not only the clinicians, but patients' families, our clinician scientists, translational investigators, basic scientists, and other staff. And we all truly can learn from each other. This is what I usually put up for thoughts for the future, and it's really the same for this. We're very lucky in EHE that we have all of this started with animal models. We need more of the natural history. I would say we need a lot more in the natural history for pediatric patients. We have to think about adaptive study design and adaptive studies, because it might not be all about what the imaging looks like if things are stable. So we have to figure out other ways like PROMIS scores, but sometimes we're leaning towards having very specific disease-oriented problem scores for our patients. So all of this is really important. And with rare disease, awareness is incredibly important, not just for industry, but also for NIH and other funding facilities. So with that, I know this was very quick because we just touched on sirolimus, but I'd like to thank the patients and families and the patient support groups. The EH Foundation has been absolutely wonderful. Our funding sources and the institutions.